So good morning. We are here again, continuing in the module 4 of the course on implementation research. So today we'll be continuing in that same vein, and we'll be looking at examples of implementation research outcomes. This chapter has been divided into 3 sections. The first section, we will describe common constructs that have been used as implementation research outcomes. And then in the second chapter, we will describe the relevance of different implementation research outcomes for different stages of implementation research. Before we proceed, it's now our practice, we're going to do some quizzes to kind of help us to gauge our knowledge and to also present some of the key messages that we'll be presenting in this chapter. So I would like you to take your pen and your paper and to answer true or false to the following questions. The first question, the following are examples of implementation research outcomes: mortality, morbidity, and disease incidence. Question 2. Implementation research outcomes are only single domain constructs and are heuristically defined. Question 3. Implementation fidelity could be assessed by examining adherence to intervention protocol and quality of delivery. Question 4. Various implementation research outcomes are relevant for research focused on different temporal stages of implementation. And the last question, fidelity measures are some of the most common implementation research outcomes used in assessing health system readiness. We begin section 1 by looking at common constructs that have been used in public health studies as implementation research outcomes. I would like to clarify that these are not the only constructs that could be used or that are examples of implementation research outcomes, but these are the common ones that you'll find across the literature, not only for infectious disease or poverty, but also across different areas of public health. So to the first construct, which is acceptability. That we define as the perception among stakeholders that an intervention is agreeable. So is this whole idea that people find the way in which an intervention is delivered to be agreeable. They have some level of comfort or some satisfaction with different aspects of implementation activities around the delivery of an intervention. And that has been called by other terms, including comfort, relative advantage, and credibility. So again, to the example that we used earlier on in chapter 1, we had said that in testing the impact of different strategies on the delivery of an evidence-based intervention, that we could use acceptability to compare the one strategy to another. And we could say to some extent that the implementation activities are successful when we have better acceptability to a strategy compared to another. Adoption has been defined here as the intention or the initial decision to try out an intervention. So is this whole idea that you contemplate to try out an intervention and you eventually make the decision to do the intervention, and then during the early phases where you're beginning to test out the intervention. So all that is a measure of adoption. For instance, if by virtue of a new strategy, people in a particular community are able to adopt some intervention compared to some other community, that in a way is useful for testing whether the set of implementation activities had worked or not. Appropriateness is the perceived fit or the relevance of an intervention, even in a particular setting. So this whole idea that because of the way an intervention is designed, or because of the makeup of a particular context in which the intervention is going to be delivered, that you could begin to imagine that there will be a good fit of an intervention into the new setting that you're intending to implement the intervention. And that, in a way, is also a measure of your implementation activities. Because you could say that in places where you have high appropriateness, you're going to achieve effective implementation and therefore achieve effective results. Feasibility, it's perhaps a very common construct that has been used even in study of implementation research. Here it is defined as the extent to which an intervention can be carried out in a particular setting or organization. So you see here it's different from appropriateness in that appropriateness looks at the perceived fit. But here in feasibility, we're actually measuring even the actual fit of the intervention into the new setting. That is to say that we cannot measure feasibility without actually delivering the intervention. And usually this measure is taken at the very early phases of an implementation activity. So we think about pilot studies that looks about what is the likelihood of success if we do this intervention in a new setting. And the likelihood of success might be determined by looking at the cost, or might be determined by looking at the acceptability of the intervention, or might be determined by looking at how effective it was for the stakeholders and the main actors in being able to deliver the actual intervention to the population that needs it. So all of these together are measures of feasibility. And as you will see from the elaboration that I provided, that there are different domains that can be used even to measure feasibility. For instance, I mentioned cost, I mentioned acceptability, I mentioned the degree of execution of the intervention. So all of these domains could be together used to measure feasibility. That is to say that the definition comes by experience. It really comes by the reason of doing of the intervention or doing of the activity, and therefore you are able to define this construct based on the actual experience of implementation. Put in another way, these outcomes are heuristically defined. Let's move on. Still talking about the common examples of constructs that are being used as implementation research outcomes. The next common construct that we're going to talk about is fidelity. So fidelity is the degree to which an intervention was implemented as it was designed in an original protocol, plan, or policy. That is to say that for every evidence-based intervention, there is a way in which the intervention was designed, or there is a way in which the intervention was originally delivered when it was being tested for effectiveness. So fidelity is being able to carry out that intervention in the way that it was originally designed in the original protocol by the designer. So anything that deviates even from the main protocol, or that deviates from the how by which the intervention was originally designed, will be a deviation even in fidelity. So there are several other names by which fidelity has been described in the literature, including adherence, delivery as intended, integrity, quality of delivery, intensity, dosage, and so on and so forth. But it's important to also highlight that for fidelity, just like feasibility, it is a multi-domain construct, because you have different domains that contribute even into the measure that we call fidelity. Implementation cost is the incremental cost to deliver an intervention in a new setting. All the cost that is associated with the implementation activities, even to carry out an intervention in a new setting, will be implementation cost. This is a single domain construct because it looks simply at monetary value of a set of activities or intervention to do an intervention in a new setting. Penetration talks about this whole idea of the vertical scale-up of an intervention within a particular system. For example, let's imagine that an intervention can only be delivered at the health facility level. Penetration will look at how many of the different health facilities in a new setting have actually carried out the evidence-based practice. It's going to be a measure of penetration, that is vertical scale-up of an intervention. And it's slightly different from coverage, which is really looking at the spread of the intervention within the community or within the eligible population that needs the intervention. That is to say that what proportion of an eligible population that should receive an intervention that actually receives it. Next, and last but not the least, is sustainability. Here we define sustainability as the extent to which an intervention is maintained or institutionalized in a given setting. That is to say that this whole idea of being able to integrate an evidence-based intervention along with its implementation activities within the larger framework or the larger health systems or the larger organization setting in which the intervention was originally delivered. This has been called by several other names, including maintenance, continuation, routinization, and institutionalization. Obviously, there are no particular way of taking this measure. What is important is to be true to the paradigm and to be true to the thinking and to be able to show the linkages between how this implementation research outcome links your intervention and your evidence-based strategy on one hand, even to the impact that you hope to see at the population level or individual health level on the other hand. So before we conclude section 1, we're going to look at some specific examples of implementation research outcomes that have been used in TDR-supported grants. It's important for you to have done the required reading at this time because the examples that we're going to be looking at in the rest of this chapter, or chapter 2, and also in chapter 3, are going to be heavily based on the required readings. So if you have not done so already, I would like you to take a pause now and go to the required readings and complete the 6 readings even before you move on. If you have done the readings already, I would like to invite you to come along with me even as we look at these examples. So the first example that we're going to look at today is really the example by Katabawa et al. And they were looking at community-directed interventions in an ivermectin control program. They looked at this study in Uganda and in Cameroon. The objective of their study was to assess this strategy and to assess its impact on the performance of community health workers. So community-directed intervention is this whole idea of empowering community even to find solution to challenges around implementation of an evidence-based intervention within their locale. The idea is that if community are empowered, they are able to direct appropriate strategy to the area of interest, even for their community. And that, in effect, will encourage or allow successful or effective implementation. And the idea was that for the community that underwent this strategy, they will be trained in the ability on how to deliver ivermectin successfully to their community members. And the training will require some cost. And at the end of the day, they will look at the coverage even of the spread or the distribution of the ivermectin even within the community where the strategy is being implemented. So in this study, coverage is an example of implementation research outcome. So they looked at the proportion of people who had received the ivermectin under the community-directed strategy, and they compared it to people who have received ivermectin under the normal status quo, where ivermectin has been previously delivered. They also looked at costs of delivering even the community-directed strategy, including cost of the implementation of the ivermectin control program within their community. And their findings were that mass treatment coverage with ivermectin increased as a result of the CDI strategy, and that implementation costs reduced over time. So in this second example, we are going to be looking at a study by Akogun et al. In Nigeria. They were looking at how nomadic Fulani communities treat malaria using some evidence-based intervention for malaria control. The objective of the study was to assess even the CDI strategy on how this improves the coverage and the acceptability even of the malaria control intervention. So specifically, they were looking at providing training to Fulani herdsmen on how to manage malaria for under 5 children using artesunate combination therapy, and also teaching them on how to properly use bed net. And in doing this, they are going to encourage the community to seek pathways, to seek ways in which they could successfully deliver the 2 intervention within their community. So it's this whole idea again of community directedness. That is to say, the communities pull heads together and to decide on how best even to deliver an intervention, or what is the best strategy to put in place for the delivery of an intervention. And we're going to be looking at how successful this community directed strategy is with regards to the current approach being used in the health system. And they measured the test of this community-directed intervention or strategy by looking at coverage and also acceptability. Coverage, they looked at to see whether people who were under the community-directed strategy had better access or better coverage of the malaria control program. And they also look at whether the people that received treatment from community members found it agreeable or were satisfied with the approach, rather than going to the health facility or going to the healthcare worker even to receive the treatment. And at the end, they found that yes, both malaria control program was acceptable to the nomadic population, and there was an improvement in the coverage overall with the community directed strategy. So in this third example, we're going to be looking at a study by Akwongo et al. And here we're looking at feasibility and acceptability of artesunate combination therapy. And the study was conducted in Ghana, Burkina Faso, Ethiopia, and Malawi. At this point, I would like to emphasize again this idea that was presented in the first module even of this course. The idea that implementation research is often done in a multi-country setting. That is to say that for us to establish generalizable evidence for a set of implementation strategy or a set of implementation activity, we have to do it in multiple settings, or in fact do it in multiple countries. And that's what you see being demonstrated by some of the studies that we are looking at even today. So for the study looking at feasibility and acceptability of ACT, the objective was to see how feasible it is to use even community medicine distributors for case management of malaria in urban settings. So the idea is that yes, community medicine distributors were being used to manage malaria for under 5 children, even in rural setting. But thinking about the fact that more and more countries in sub-Saharan Africa are becoming urbanized, so they try to see whether the same strategy, that is to use community medicine distributor to deliver an evidence-based intervention, would work even in urban setting. And then to determine whether this strategy is going to work or not, or whether the set of implementation activities that they're going to put in place is going to work, they looked at specific measures of implementation research outcome. They looked at fidelity, that is to look at for all of the community medicine distributors that were trained, to what extent did they deliver even the intervention as they were trained, according to the protocol in terms of the dosage, the frequency by which the children should receive the intervention. They also look at the coverage, that is to say the number of children who should receive the malaria treatment, the appropriate malaria treatment, how many of them did receive the treatment. And then they look at feasibility. This whole idea that is it even possible for us to be able to do this in an urban setting at all? Is this actually feasible? And at the end of the day, they concluded that yes, case management of malaria could actually be done successfully by community medicine distributors, even in urban setting, based on the changes in fidelity, coverage, and feasibility. So for the fourth example, we look at a study by Okebuno et al. In Nigeria and in Togo and in Cameroon. They are looking at the use of community-directed distributors of ivermectin for other public health control programs. So this whole idea that yes, we have these community distributors within our villages, our rural areas, that is to say, can they be used also even for some other public health program, including like sanitation, immunization activities, and so on? And does this inclusion negatively impact even their activities, even in delivering the ivermectin control program that they were originally slated for? And in studying this, they looked at specific implementation research outcome. First, they look at feasibility. That is to say, is it possible at all to actually incorporate additional tasks for these community distributors of ivermectin control program? For instance, could they be involved even in sanitation? Could they be involved in immunization and nutrition program in their community, without that negatively or adversely affecting their work in ivermectin control? And they also looked at coverage. That is to say that does the proportion of people that received ivermectin changes with the inclusion of additional tasks for these community distributors in their community? So at the end, they concluded that yes, involvement of these community-directed distributors in other public health activities, even in their community, did not have any negative impact even on the ivermectin control program. So far, we have looked at 4 different examples of implementation research studies that were done using implementation research outcomes as a measure of effectiveness of implementation activities in different parts of sub-Saharan Africa. When we come back, we will continue with 2 additional examples, And then we'll look at other usefulness of implementation research outcomes, such as implementation research outcomes being used for the assessment of health systems readiness, and the relevance of implementation research outcomes for different stages of implementation or implementation activities.